You all, very warm welcome to today's webinar, Neuro Micro paper presentations. And I'm Professor Pupule, Professor and Head of the Department of Neurology, Yangon General Hospital, University of Medicine 1. And I will be chairing this session together with the Professor Chuchu. And in this section, we have to present the 4 papers, 3 neuro papers and 1 micro paper. And each speaker has 10 minutes for presentation and 3 minutes for discussion. And Q&A section will be at the end of each presentation. And first of all, now I would like to introduce the first speaker, Dr. Omar. She's an associate professor from the Department of Neurology, Yangon General Hospital, University of Medicine 1, Yangon. She is not only a neuromuscular expert, but also the young, successful, active researcher. And she is currently attending the postgraduate program on the organ donation innovative strategies for the Southeast Asia. The topic she will present is monitoring death by the neurological criteria and identifying barriers from the brain death diagnosis. And may I call upon Associate Professor Dr. Omar for your presentation. Omar, အတန်မကြားရအောင်အတန်မကြားအောင် Omar
ကြားလားမ
အခုကြားပြီပြောအစပြောရမရအောင်နော်ရပြီပြော
Diagnosis of brain death is mainly clinical and it is based on highly specific neurological examination of probable brain death is defined by irreversible severe neurological damage with the patient age is without sedation and absence of
အမအတန်မကြားသေးဘူး
ကြားလားအတန်မကြားအခုရပြီ
ကတော့အကုန်ကြားတယ်
ဟုတ်လား
အဲ့ဆိုပြန်ဟိုလုပ်ပြရမလားအမခဏလေးပြန် share ပြရမလားမ
အတန်ကိုနည်းနည်းလေးကျယ်လိုက်ရင်နော်
ခဏလေးနော်ပြန် share ပြမယ်objective. Our aim was to identify the barriers for brain death diagnosis at main ICU of Yangon General Hospital. Our objectives were to identify the probable and confirmed brain death cases, to study the monitoring of death by neurological criteria in these cases, and to determine the main hospital barriers for the diagnosis to become the confirmed brain death. So it was the prospective descriptive study, and it was done in main ICU and neurosurgical ICU of Yangon General Hospital, and we have recruited consecutive probable and confirmed brain death cases over a period of 6 months from 20th February to 90th August 2020. Our inclusion criteria include probable and confirmed brain death cases. These definitions I have mentioned in the previous slide. So let us move on to the results and discussion. This graph shows the number of patients recruited during our study period. So you can see, roughly, we have 3 brain death cases a month in the ICU of Yangon General Hospital. This number is actually very few compared to the 2,000-bedded Yangon General Hospital. So the reason is that in our ICU, the beds are quite limited because we have only 20 beds in the main ICU and 4 beds in the neurosurgical ICU. Another thing is that here you found in some of the months we haven't recruited any cases. So it can be beautifully shown by this graph. Here you can see the blue line graph shows the number of COVID-19 cases in Myanmar. This is the COVID-19 first wave, and this is the start of the COVID-19 second wave. The red line graph shows the number of the brain death cases that we recruited during our study period. So here you can clearly see that we have very few cases. It is because of the COVID-19 situation. So among our cases, 57.1% were male and 42.9% were female. What about the causes of brain death in our patients? Most common cause is traumatic brain injury, 71.4%, and 14.3% was due to CNS infection, and another 14.3% was due to stroke. Among the traumatic brain injury cases, 85.7% was due to road traffic accident, and 14.3% due to fall from height. All of our traumatic brain injury cases were very severe with polytrauma, including multiple bone fracture, gut perforation, spinal rupture, and hemopneumothorax. So now let's look at the timeline of brain death cases. Average time from hospital admission to ICU arrival was 18.2 hours. It means all our brain death cases were very severe on admission, so they had to be admitted to ICU within 24 hours of admission. Mean duration of ICU stay of our patients was 5 days, and average hospital stay was 6 days. Time from GCS3 to first set of brain death determination test was 13 hours. What about the observation period? Observation period means the waiting period from when we suspect the brain death diagnosis until when we start the first set of brain death determination test. So this is the observation period. To be sure, our local SOP or guidelines recommend at least 4-hour observation period before we start the brainstem testing the brainstem reflexes to confirm the brain death. However, in our study, we have found out that average observation period was 8.9 hours, which is longer than that recommended in our SOP. Another thing is, in 28.6% of the patient, we have found out that there was no observation period. So it means we need to improve awareness to local brain death SOP among our healthcare professionals. In addition, our local SOP recommends to do the brainstem test, 2 times. And then it stated that we don't need any time interval in between the 2 sets of tests. So in our study, we have found out that brain death determination was done twice according to the guidelines in 85.7%. And average length in between the 2 determination was 13.4 hours, although we recommend there is no time interval needed. Average duration between brain death and circulatory death among our cases was 41.9 hours. Average duration between brain death confirmation and ventilator off was 42.04 hours. So it means all of our patients had their ventilator off only after the circulatory death. Here you might know that after brain death, ventilator or other organ support must be stopped. However, it is contradictory in our situation. So the reason might be because majority of our doctors are used to defining death by circulatory criteria. So they are waiting until the patient had got circulatory death. Another reason is there might be poor knowledge on procedures after brain death. Other reasons might include social-cultural reasons because the patient relative might request for prolonged life support. According to the World Brain Death Project's recommendation and suggestion, a person who is brain dead is legally dead and there is no chance of recovery. So after declaration of brain death, somatic or organ support should be discontinued except for 3 conditions: when the organ transplantation is planned, or that the deceased patient is pregnant for the sake to support the fetus, or when the family requests for religious or moral beliefs. So we can conclude that public awareness of brain death and its implications, approach the situation when the family requests for prolonged life prolonged organ support, and clear medical legal guidelines are very important to establish in our case. At the time of ICU admission, we have found out that 85.7% of our cases are medically suitable for organ donation. However, along the course of admission, after the full assessment, we have found out only 57.1% were medically suitable for organ donation. The reason were hepatitis C virus infection, septicemia, disseminated active tuberculosis. So it means communicable diseases are still very common in Myanmar, and it might hinder the rate of organ transplantation in our country. So let us move on to see how many of our probable brain death cases has become confirmed brain death and what are the barriers. We have found out that facial movement to nausea stimuli or pain was not recorded in 57.1% of our patients. Oculocephalic, oculovestibular reflexes were not done in 28.6%. Apnea test was not done in 57.1%. And second set of brainstem tests was not recorded in 14.3%. Medical record of brain death was not recorded in all the patients because all the patients were recorded only at the time of circulatory death. So unfortunately, we have to say that according to the definition of confirmed brain death, all of our probable brain death cases has not become confirmed brain death in our study. So what are the barriers for brain death diagnosis? The main barrier is poor documentation. Others include limited time, limited manpower, lack of enough equipment, and some of our doctors are less experienced in doing a special test like apnea test. There was also financial concern on the cost of repeated arterial blood gas analysis during the apnea test. And also we have found out that there was less familiarity to look at brain death SOP among the healthcare professionals. And also, our current SOP has some weak points, especially in clarifying the number of apnea tests necessary to confirm the brain death, and also it is weak in emphasizing the brain death diagnosis. So, I would like to conclude that we have studied monitoring of death by neurological criteria, and we have identified barriers to confirm brain death diagnosis in the 2 ICU of Yangon General Hospital. The main barrier was lack of proper documentation, and other barriers include reduced awareness of local brain death guidelines, lack of enough human resources, equipment, time, and expertise in doing the special test, and cost limitation in doing the apnea test. However, this study has helped us to understand the current hospital situation, and it has improved our practice and skill required in the brain death certification. So we would like to recommend to use a standardized checklist for brain death determination to be systematic. And then we need proper documentation when doing the brain death confirmation. And it is necessary to improve our existing knowledge to ensure our brain death confirmation practices are up to date, systematic, and consistent. So training of trainers courses on determination of brain death should be organized, and it is high time to revise the current local guidelines according to the recent international consensus. And we need to reinforce to adhere to local and international brain death guidelines in practice. So it will finally also help us to improve plans with organ donation in future. These are my references. Thank you for your kind attention.
And thank you, Dr. Omar, for your interesting paper. Now, floor is open for discussion regarding this paper. And I have one question for Dr. Omar that you presented the main barrier was the lack of the paper documentation. So I'd like to know that how will you solve this problem?
Yes, Amma, thank you for your questions. Yeah. So I have also included in one of my recommendations. So what I would like to suggest is in our SOP or local brain death guidelines, we have also included 2-page for the brain death confirmation checklist. So when we are going to do the brain death certification. If we are doing with a standardized checklist, and then it is like we have already documented all the process, because the checklist also include final, signing of the brain dead confirmed doctors also.
Yes, I agree. Checklist is important, and we have to do this. No, another question is just a curiosity. How much do you need to pay for the apnea test?
Yeah, for the apnea test itself, it is free of charge because it is done by our ICU doctors. So, but the thing is, arterial blood gas analysis, during the apnea test, we have to do at least 2 arterial blood gas analysis, and sometimes, if necessary, if the test is prolonged, we need 3-4 tests. But this arterial blood gas analysis cost. That's why, sometimes we need to consider, because in our country, even after brain death, they are still used to continuing the life support until the patient got circulatory death. So the doctors from their side also, they think that if they do apnea test, and then if they, take the cost of the arterial blood gas analysis, after all, nobody, for the moment, nobody is stopping the ventilator.
Okay, thank you. The last question is, you said that the common causes of the brain death was a TBI in your paper, and I would like to know what about the hypoxic ischemic brain injury? What is the percentage?
Oh, but in my case, it is only 14.3% for the hypoxic brain injury. There are, it depends because, I think for the traumatic brain injury, because our ICU has limited bed availability. So, so when they take over the case, for the ventilator also, they need to, I think they need to, prioritize or justify for the ICU beds. Some of the traumatic brain injury cases, although severe, sometimes they try to save, So, and then they are also going through the emergency. So mostly through the emergency,
yeah.
they are very easy to go to the ICU beds also, But for example, like if the patient got arrested in our medical wards, sometimes they just do the, CPR, and then they ended like that, It is difficult to get, ICU consultant to come and put in the ETG.
Okay, thank you, Dr. Uma. And now I will move on to the second speaker, Dr. Mumumu. She is a lecturer from the Department of Neurology, University of Medicine, Mandalay. She is going to talk about the relationship between the nerve conduction study and the clinical severity in patients with the carpal tunnel syndrome. Shall we welcome Dr. Mumumu? Now I'd like to call upon the The third speaker, Dr. Min Tae Nan, he is a lecturer from the Department of Neurology, University of Medicine 2, Yangon. And he will talk about the hypertriglyceridemia and the peripheral neuropathy in the HIV infective patient. And please join us in the welcoming Dr. Min Tae Nan.
ကျေးဇူးပါမှာပဲစလိုက်မယ်မှာပဲ
Good afternoon, Chairperson, Professor, my senior junior colleague. I am Dr. Medanan from the Department of Neurology from University of Medicine 2. Today, I would like to present hypertriglyceridemia and peripheral neuropathy in HIV-infected patients. Introduction: significant effects in the management of HIV infection, such as effect of highly active antiretroviral therapy led to longer lifespan. A longer lifespan also means an increased prevalence of certain neurological disorders due to longer duration of infection and toxicity of the use of multiple drugs. Of the disorder, this is polyneuropathy, the most common neurological complication and major cause of morbidity in HIV-infected patients. It is frequently misdiagnosed or delayed in diagnosis, leading to a bad effect on the overall health and quality of life. A new study emerged in 2011, which concluded that elevated triglyceride level increased the risk of HIV-70 neuropathy in HIV-positive individuals, independently of other known risk factors. In HIV patients, they are aging due to improve longevity with the combination antiretroviral therapy. Both hypertriglycemia and 70 neuropathy are increasing common. In 2004, a study showed hypertriglycemia as one of the significant risk factors for development of chronic idiopathic external polyneuropathy. Emerging advanced technology such as nerve conduction machine has allowed the patient to undergo nerve conduction study before clinical symptoms appear and the disease severity can be determined. The result from the investigation can be greatly helpful in the prevention aspect of HIV peripheral neuropathy, as one of the important risk factors can be detected early and can easily be prevented. Madam, this study was a hospital-based cross-sectional analytical study conducted on the 88 HIV patients. The study was carried out only after getting approval of the ethics review committee of University of Medicine 2, Yangon. Patients who fulfilled the licensing criteria were chosen by using systemic sampling method. After taking infant constant, nerve conduction study was done and blood triglyceride level was measured. Categorical variables were summarized in the frequency and abundance, and potential variables were described in mean and standard deviation compared using independent sample t-test. Categorical variables were analyzed using paradigm transfer test. Correlation analysis of the result was done using the cross test. Statistically significant level were determined at the value less than 0.05. I would like to present findings. Figure 1 shows the age distribution of study population. The majority of patients were between 31 and 15, the age being 33.18 years. The oldest patient was 73-year-old and the younger 22 years. This is the figure 1. Figure 2 shows the distribution of the study population. Male patients outnumber the female patient by 24. Figure 3 shows the ARD regime the patient were taken. Most patients, 93.18%, were being treated with first-line ARD regime, and 6.82% of patients they have not been on any ARD regime. Figure 4 shows the percentage of patients with hypertriglyceridemia, defined as the more than 150 milligram per deciliter. More than half of the patients, 65.9%, have hypertriglyceridemia at the time of study. Figure 5 shows the proportion of HIV patients who have peripheral neuropathy according to nerve conduction study. Almost 1/3 of patients, 34.1%, have evidence of peripheral neuropathy on nerve conduction study. The type of neuropathy on the patient was adrenal type. Table 1 shows the mean value of tacit motor nerve, ANA and TBN in patients with abnormal nerve conduction study finding. The mean amplitude of ANA nerve wave provide table 1 millivolt and emit velocity were 64.5 meter per second. The normal value for ANA motor nerve are more than millivolt for amplitude and more than 49 meter per second for velocity. The mean amplitude of TBN nerve were 8.14 millivolt and its velocity were 47.09 meter per second. For TBNN, number value are more than 4 millivolt for amplitude and more than 41 meter per second for velocity. That's table 1. Table 2 show the mean value of amplitude and velocity of anomalous conduction study. The mean amplitude on a nerve were 12.25 microvolt and its velocity were 16.74 meter per second. The number value for ananap are 70 microvolt for amplitude and more than 50 meter per second for velocity. The mean amplitude of student nerve were 2.16 microvolt and the mean velocity was 48 meter per second. The number value are more than 6 microvolt for amplitude and more than 40 meter per second for velocity. This is the table 2. Table 3 shows the comparative mean triglyceride level between HIV patient with peripheral neuropathy and HIV patient without peripheral neuropathy. HIV patient with peripheral neuropathy had mean triglyceride level of 274.43 mg per deciliter and range from 700 mg per deciliter to 180 mg per deciliter. HIV patient without peripheral neuropathy had mean triglyceride level of 180 mg per deciliter. This is the table 3. They show the association between triglyceride level and neuropathy. Evaluate statistically significant. Our 88 patient, 58 patient had hypertriglyceridemia. Among them, 30 patient, 34% to the population neuropathy. Other 28 patients did not have neuropathy. Other 30 patients, 34% to the population did not have both hypertriglyceridemia and neuropathy. Discussion. In a study, 58 patients, 35.9% of study population had hypertriglyceridemia, and out of these 58 patients, 30 patients, 51.17% had peripheral neuropathy. The neuropathy was central and moderate abdominal neuropathy type, predominantly moderate upper limb and predominantly central in lower limb. The association between hypertriglyceridemia and peripheral neuropathy was statistically significant. There were no statistically significant correlation between hypertriglyceridemia and each parameter of abnormal nerve conduction study finding, such as amplitude, distal latency, and conduction velocity. Conclusion. The study highlighted the association between hypertriglyceridemia and peripheral neuropathy in HIV-infected patients. Peripheral neuropathy is an undiagnosed problem as who have patient heteroheart do not appreciate the importance of clinical problem. The study showed that hypertriglyceridemia is becoming an important risk factor for neurological problems such as peripheral neuropathy. When an HIV patient understands lipid anomalies such as hypertriglyceridemia, a care provider should be aware of not only cardiovascular problems but also neurological problems such as peripheral neuropathy. By means of controlling hypertriglyceridemia aggressively and effectively, not only metabolic complications but also neurological complications can be prevented. The reference for the study is the photo of the SCS machine. Thank you for all of our guidance.
Thank you, Dr. Min Tây Nai, for your excellent paper. Now it's a time for question to Dr. Min Tây Nai.
Okay, bà.
Chú mấy chứ đâu bà?
Okay, bà. Okay, mấy bà.
Alicia, Amati de Laudo, Hyper DG ga, peripheral neuropathy ma, tuga no? So you study the hyper DG in peripheral neuropathy in HIV patients. So do you have any specific idea or do you want to do any specific application on that?
hypertriglyceridemia မှာဟုတ်ကဲ့ဟို neuropathy တိုင်းတော့မှ hypertriglyceridemia တက်တာတော့မဟုတ်ဘူးမှာဟို hypertriglyceridemia တက်တဲ့ patient တွေတချို့ neuropathy ရှိတယ်ပေါ့နော်အဲ့ one of the risk factor ပေါ့ HIV မှာကြတော့မှသူကဟို hypertriglyceridemia တဲ့ complication of the disease ရဲ့ complication တခုပေါ့နော် neuropathy ကလည်း complication တခုဆိုတော့မှအဲ့နှစ်ခုရဲ့ဟိုလုပ်ကြည့်တာပါမှာဟုတ်
neuropathy ကဟို disease တော်တော်များများမှာ neuropathy လို့ပြောလိုက်ရင် DG နဲ့သူတို့ correlate လုပ်ကြတယ်လေ
ဟုတ်ကဲ့ပါမှာဟုတ်
ဆရာက neuropathy ဆိုရင် hyper DG ပေါ့ဟို diabetes ဆိုပါတော့အခုကျတော့ HIV ဆိုတော့ဆရာမှာ any ဟိုဒါကိုကြည့်ပြီးဆရာတခုခုများ you want to do something more ပေါ့ဘာများသိချင်တာဘာများထပ်ပြီးတော့ဆရာ specify လုပ်ချင်လို့လဲ just neuropathy ပဲလားဒါမှမဟုတ်ဆရာ nerve ကိုတခုခုများဆရာဆက်ပြီးစဉ်းစားနေရလားပေါ့နော်
ဟုတ်ကဲ့မှာဟုတ်ဒီမှာတော့မှဟို neuropathy ရတော့မှတခါကျရင်မှာဟိုလက္ခဏာတော့ဟို triglyceride ကတော့မှဟို HIV patient တွေမှာဟို medication လုပ်တော့မှတည်တယ်ပေါ့မှာ neuropathy ကတော့ဟိုတောင်းတောင်းဟိုတိတ်ပြီးတော့ဟိုလက္ခဏာမပြရင်လူနာကလည်းတတိမသားမိဘူးဟိုတောင်းဝင်ကလည်းတိတ်ပြီးတော့ဒါဟိုပါပေါ့နော်ဟိုစိတ်ဟိုမဖြစ်မိဘူးပေါ့နော်ဟိုမဖြစ်မိဘူးပေါ့ဒါပေမဲ့ကျွန်တော် NCA ကြတော့မှဟို mission ကတော့ခါကြရင်လည်းဟို sub clinical ကိုလည်းကျွန်တော်တို့ကကြိုပြီးတော့တည်တယ်ဆိုတော့ဟိုဒီလက္ခဏာမပေါ်သေးလဲပေါ့နော်ဒီ hyperglycemia ရှိရင် neuropathy ဖြစ်လာဟိုလက္ခဏာမပေါ်သေးတဲ့လူကလည်းဖြစ်လာနိုင်တယ်ပေါ့မှာဖြစ်လာနိုင်လို့ရှိရင်ကျွန်တော်တို့ကဟို hypertrophy ရတော့မှ treatment တော့ပေးရမယ်ပေါ့နော်ဒါပေမဲ့ဒါကိုပေးခြင်းအပြင်ခုနပြောလို့ cardiovascular ရော neuro complication ရောပါဟို prevention ဖြစ်တဲ့ဟာကိုပြချင်တာပါမှာဟုတ်ကဲ့
Okay thank you ပါဆရာ
ဟုတ်ကဲ့ပါမှာကျေးဇူးပါမှာ
Thank you Dr. Mintainai for your question and also thank you for asking question Mamaju and now we will move on to the second speaker, Dr. Momo Moon. She is a lecturer from the Department of Neurology, UM Mandalay. And I apologize for the delay of Dr. Momo Moon paper because it is a shortage of the electricity. Now, may I call upon Dr. Momo Moon? And she will talk about the relationship between the nerve conduction study and clinical severity and patients with carpal tunnel syndrome. Dr. Momo Moon, please.
Dr. Momo Moon, can you unmute your microphone?
Momo အတန်မကြောက်
We can hear.
အဲ့လိုပဲဖြစ်သွားလို့ share sound လုပ်လိုက်ပါ
Most common type of enteropathy
Okay,
which
yeah. We hear you.
The prevalence ranges from 2.7 to 5.8% according to several studies, with the incidence of 276 per 100,000 per year. It occurs more frequently in women than in men, with a prevalence of 9.2% in women and 6% in men, with a big age range 40 to 60. Patients commonly present with numbness and tingling in the median innervated fingers, which wakes them at night. Symptoms are mild and infrequent at the onset, and in about 1/3 of patients, it may resolve spontaneously for months or years. But in some patients, the disease progresses and the weakness and finally wasting of the aorta pollicis brevis is usually a late features of severe compression. Diagnosis of carpal tunnel syndrome is based on clinical symptoms, physical signs, and nerve conduction abnormalities. Nerve conduction studies is considered as gold standard test for diagnosis of carpal tunnel syndrome, but not only for diagnosis, it is being increasingly used for severity assessment of carpal tunnel syndrome with high degree of sensitivity and specificity. In addition to an accurate diagnosis, it is important to note the severity of carpal tunnel syndrome, which is based on NCS and clinical skills. Among various clinical skills, historical objective skill is claimed to be both physician and patient-oriented data, appeared simple to use and is useful to assess clinical severity of carpal tunnel syndrome patients. As severity assessment of carpal tunnel syndrome is a crucial step for defining prognosis and therapeutic measures, many studies have been carried out to assess the relationship between clinical severity of carpal tunnel syndrome and electrodiagnostic findings. However, it has been a subject of debate whether clinical manifestations of carpal tunnel syndrome correlate well with neurophysiologic findings. So, this study is aimed to assess the relationship between NCS and clinical severity in patients with carpal tunnel syndrome. This study is cross-sectional descriptive study. Study site is at outpatient department of Department of Neurology, Manly General Hospital, and it's a study period from March 2018 to September 2019. Inclusion criteria: patients with symptoms suggestive of carpal tunnel syndrome who fulfilled the American Academy of Neurology clinical diagnostic criteria of carpal tunnel syndrome. Clinical criteria is fulfilled when at least one of the following mentioned clinical symptoms along with one or more of the clinical signs are present. From history, any of these symptoms in the median distribution: dull, aching, discomfort in the hand, forearm or upper arm, paresthesia in the hand, weakness or clumsiness of the hand, dry skin, swelling or color changes in the hand. And clinical signs may be normal. Symptoms may be elicited by tinal signs or phallic signs, sensory loss in the median distribution, weakness or atrophy in the thenar muscles, dry skin on thumb, index and middle fingers. Patients with carpal tunnel injuries, previous hand surgery, cervical radiculopathies, brachial plexopathy, and polyneuropathies were excluded from this study. After confirming the diagnosis, clinical severity was assessed by high OB scale, and which is followed by nerve condition studies of both upper limbs to assess electrophysiological severity. In patients with bilateral carpal tunnel syndrome, the electrodiagnostic group in the most severely affected hand was noted. Historical objective skills has 5 grades. Grade 1, nocturnal paresthesia only. Grade 2, nocturnal and diurnal paresthesia. Grade 3, sensory deficit elicited by testing hypoesthesia to pain. Grade 4, hypertrophy or motor deficit of the thenar muscle innervated by median nerve. And grade 5, plegia of thenar muscle innervated by median nerve. For study purpose, grade 1 and 2 were considered as mild to moderate carpal tunnel syndrome, while grade 3, 4, and 5 as severe carpal tunnel syndrome. Then NCS was done using the standardized diagnostic protocol according to the AEM criteria by using the nerve conduction machine 2-channel Neuropac S1. For comparison purpose, electrophysiological classification of carpal tunnel syndrome was as follows. In mild to moderate group, abnormal findings on comparative study or abnormal sensory peak latency or abnormal digit wrist segment sensory contraction velocity and normal distal modal latency, or abnormal digit wrist segment sensory contraction velocity and abnormal distal modal latency. In severe group, absence of sensory nerve action potential, snap in the digit wrist segment and abnormal distal modal latency, and or compound muscle action potential absence. Data were collected by using Proforma. Data analysis was performed by using Stata 13 statistical software. To determine the relationship between NCS and clinical severity, chi-square test was used. During the study period of 1.5 years, a total of 63 patients with carpal tunnel syndrome were included in this study. Age ranged from 26 to 78 years, with mean age 50 plus or minus 11.98 years. And the highest percentage belongs to the age range between 40 and 65 years. In this study, mean age was 50 plus or minus 11.98 years, and it is comparable with the studies done in Pakistan and India and follows the normal distribution. The most common age group was between 40 and 65 years, and similar findings were found in Singapore and India populations. According to the studies, the incidence of carpal tunnel syndrome increases with increasing age and becomes a problem of middle-aged people. Among 63 patients, female were 50 and male were 13, with female to male ratio of 3.84:1. In this study, majority of the patients were female, and it is comparable with the findings done in India and UK studies. This increased incidence in women might be due to hormonal factors which cause fluid retention during pregnancy or menopause and propensity of musculoskeletal problems among women. Among 63 patients with carpal tunnel syndrome, 17 patients were found to have mild to moderate clinical severity and 46 patients were having severe clinical severity. Out of 63 patients, 43 had mild to moderate NCS severity and 20 had severe NCS severity. Then, relationship between nerve conduction study and clinical severity has been assessed, and it's found out to be statistically significant with the p-value of 0.038. Tierney et al. And Ali et al. Also reported that there was highly significant positive relationship between historical objective skill and neurophysiological classes, and which means that historical objective skill could be a reliable clinical score of clinical severity of CTS and reliably reflect the MCS severity. Regarding mild to moderate clinical severity group, 88% had reviewed relevant neurophysiological severity, and it pointed out that this clinical entity might need not to be confirmed by MCS for severity assessment. However, in clinically severe group, only 39% revealed severe MCS severity, and which means that patients with severe grading should undergo non-conduction study to precisely indicate the severity of the disease. Conclusion. Historical objective skill could be a useful tool in severity assessment of carpal tunnel syndrome in resource-limited areas. In this study, historical objective skill was well related with MCS in mild to moderate clinical severity, but not in clinically severe groups. Therefore, nerve conduction study remains important for confirming the severity of carpal tunnel syndrome, especially in severe clinical entity. These are the references. This is my end of presentation. Thank you for your kind attention.
And thank you, Dr. Mumumu, for your wonderful paper. And now welcome for questions from the audience regarding this paper. So I have one question for Dr. Mumumu. And in your study, what are the underlying causes of the carpal tunnel syndrome in the severe cases?
Underlying disease network
underlying causes or whatever the underlying causes or the occupation, etc.
Okay, occupation association housewife 50% about 50% of the population ရှိပါတယ်မှာအဲ့နောက်မှာတော့ sales person တွေနောက်တချို့က clerk နောက်ပြီးတော့ဆရာဝန်3ယောက်နောက်ပြီး nurse 1ယောက်အဲ့လိုမျိုးတွေတော့တွေ့ခဲ့ပါတယ်မှာဟုတ်
what about the repetitive work or the handling the vibrating tools, etc.?
Okay, housewife တွေမှာ housewife တွေဒီ clerk တွေ sales person တွေကတော့ repetitive hand or movement တွေနဲ့တော့ association ရှိပါတယ်မှာနောက်တစ်ခုကကျတော့နောက်တစ်ခါကျတော့တခြား disease နဲ့ association မှာတော့ဟို diabetes mellitus patient တွေကို 23% လောက်မှာတွေ့ခဲ့ရပါတယ်မှာဒါပေမဲ့တခြား hypothyroid တို့ arthritis တွေတို့အဲ့မျိုးနဲ့တွေ့တဲ့ဟာတော့မတွေ့ခဲ့ပါဘူးမှာဟုတ်ကဲ့
Okay, thank you. And for your most of the cases, was it more in demyelinating or more in the axonal?
Okay, အများစုကတော့ demyelinating မှာဟုတ်မှာ
Okay, okay. Thank you. Thank you very much. And now I'd like to hand over to the Professor Chuchu Wu for the microbiology paper presentation.
Thank you, Professor Pipule. I will continue for the last speaker. The last speaker is Dr. Amy San. She is a lecturer from the Department of Microbiology, University of Medicine 1. She got her PhD in medical microbiology from University of Medicine 1 in this 2020. So I call upon Dr. Amy San to give presentation. Amy San ပြောနေပြီလားအတန်မကြားရဘူး Amy San unmute မှကြားပြီ
ဟုတ်ကဲ့ရှင့်မ
ဆိုတော့မကြားဘူး
Good afternoon, Chairperson, professors, my senior and junior colleagues. Today, I would like to talk about fecal carriage or carbapenem-resistant enterobacteriaceae in selected community. Let's move for introduction. Bacteria resistant to carbapenem represent one of the significant global health challenges of the centuries. This is particularly important in developing countries where antibiotics are available over the counter. Many studies highlight the incidence of carbapenem-resistant enterobacteriaceae isolated from clinical samples. However, there has been little research published in fecal carriage or carbapenem-resistant enterobacteriaceae in any asymptomatic population. Nowadays, carbapenem are important therapeutic agents for multi-drug-resistant gram-negative bacteria. This is because these drugs have the broad-spectrum activity. The emergence of carbapenem-resistant bacteria is due to the increasing use of carbapenem in the hospital settings. However, carbapenem-resistant enterobacteriaceae resistant to carbapenem often show high resistance to other antibiotics, such as cephalosporin, quinolones, and aminoglycoside, leaving few or no optimal therapeutic option. Asymptomatic fecal carriage of carbapenem-producing bacteria in a community has been reported from many countries. Very high prevalence rate has been reported from India. Very low level of carriage rate has been reported from European countries. In Asia, the data analysis from 49 countries during the period of 2001 to 2012, enterobacteriaceae resistant to imipenem and meropenem are both 0.5 in the first period. The last period, the resistance rate of both drugs is 1.2% and 1.3% respectively. So resistance rate of carbapenems are increasing trend from 2000 to 2012. The rapidly increasing carbapenem resistance in enterobacteriaceae is a particularly serious problem worldwide, leading to increased morbidity, mortality, and health system causes. The aim of this study is to study fecal carriage of carbapenem-resistant enterobacteriaceae among community in selected community in Yangon regions. This study provides antimicrobial susceptibility pattern of enterobacteriaceae in normal healthy person in selected township or Yangon regions. And then this research provides knowledge to help the clinician in choosing appropriate and effective antibiotics for the treatment of carbapenem-resistant enterobacteriaceae and help in the implementation of guidelines for antibiotic policy. Let's move on method. This study is a community and laboratory-based cross-sectional descriptive study was conducted January 2018 to November 2019. The study population was recruited from Tonte, Komu, Shrevida, Yangin, Minglado, Lamro, and Sanjiao Township by using cluster sampling method. Study population was selected according to inclusion and exclusion criteria. Inclusion criteria consists of healthy person more than and equal to 13 years. Exclusion criteria are history of hospitalization within 1 month, presence of diarrhea or dysentery within 1 month, history of antibiotic therapy in the last 1 month. This study was conducted after receiving the approval of Academic Board of Study and Research and Ethics Committee, University of Medicine 1 Yangon. The stool sample did not meet with urine and disinfectants, collected in a sterile white mouse crooked containers, and the stool sample was inoculated on chromogenic agar at 37 degrees Celsius. After overnight incubation, the agar plate were examined microscopically for discrete colony. Discrete colony were considered as presenting carbapenem-resistant enterobacteriaceae colonies. Identification and antimicrobial susceptibility testing of the isolated bacteria were done by Vita-2 compact system. Result. A total of 1,480 healthy persons was participated in this study. Among them, 42% were male and 58% were female. Age distribution of the study population was noted within an age range of 30 to 86 years. Out of the stool sample, 57 enterobacteriaceae were isolated by meropenem containing screening method. Among 57 isolate, 41 isolate show carbapenem resistant by Vita-2 compact system. Among carbapenem-resistant Enterobacteriaceae, the prominent bacteria were Escherichia coli, 95%, followed by Klebsiella pneumonia and Enterobacter cowhei. This figure shows antimicrobial susceptibility pattern of isolated Escherichia coli. Escherichia coli show 100% resistant to ampicillin, ampicillin sulfaten, amoxicillin and clavulanate acid, and sulfazoline and azithromycin. But meropenem and meropenem and ibuprofen shows 95% and nitrofurantoin was 8% only. This data show antimicrobial susceptibility pattern of isolated Klebsiella pneumoniae and Enterobacter cowhei. Klebsiella pneumoniae show 100% resistant to the drugs tested in this study, but Enterobacter cowhei show resistance to imipenem and meropenem, but sensitive to ceftriaxone, sulfazoxine, and cefotaxime. This figure 2 shows distribution of carbapenem-resistant Enterobacteriaceae from different townships or Yangon region. According to the township, most of the carbapenem-resistant Enterobacteriaceae isolate well detected from the Sanjiang township, 43.9%, followed by Lamro township. Dongde and Komu township show no carbapenem-resistant isolate in this study. Let's move on discussion. This study explored the prevalence of carbapenem-resistant Enterobacteriaceae in the normal healthy person in selected township or Yangon region, and necessary use of antibiotics without prescription for the treatment of bacterial infection may lead to the emergence of antibiotic resistance in common pathogens. The antimicrobial resistance can make easily treatable illness a dangerous infection, leading to increased morbidity, mortality, and health system causes. It can spread to the family members and community through the different means. In the present study, 41 isolate or Enterobacteriaceae show carbapenem resistant by vital to combat system. So colonization of carbapenem resistant Enterobacteriaceae in community was 2.7%. In China, colonization of carbapenem-resistant Enterobacteriaceae in community was 2.4%, which is similar to the present study. However, carbapenem-resistant Enterobacteriaceae were isolated from 10% of children in India. Although the number of the positive cases is small, but it suggests the prevalence of carbapenem-resistant Enterobacteriaceae in healthy persons does exist. The colonization of the carbapenem-resistant Enterobacteriaceae in healthy asymptomatic population may contribute to the later infection in the hospital setting. Escherichia coli is a facultative anaerobic gram-negative bacteria commonly found in the intestinal tract of the warm-blooded animal. Shared distribution of Escherichia coli in the skin of the human and its susceptible nature to antibiotics make it a good indicator bacteria to study the emergence of antibiotic resistance. In this study, Escherichia coli account for 95% of all carbapenem-resistant isolate. According to the result, Escherichia coli resistant to commonly used antibiotics in healthcare setting in Myanmar. However, resistant to nitrofurantoin was only 8%. This is due to the least prescribed antibiotics in a hospital setting in Myanmar. The study of antibiotic susceptibility pattern of fecal Escherichia coli in apparently healthy person in Naukla Township in Yangon region in 2017 reported no carbapenem-resistant Escherichia coli was detected. This is due to the relatively small number of samples and equal to 100 at different townships in Yangon region. The reported asymptomatic fecal carriage rate of carbapenem-resistant Escherichia coli in a community varies in Asian countries. 0.46% in Nepal, 2.2% in Korea. Back India and Taiwan show no carbapenem-resistant Escherichia coli in a community. This may be due to the both India and Taiwan study were done in a young children who have less exposed to various antimicrobial agents and small sample size. In Myanmar, the study done in clinical samples have reported that carbapenem-resistant Escherichia coli were 1.8% in the Zhou study, 15% in Miet et al. Study, 6.2% in Mi Wenhua study, 12.9% in Sun study. In the present study, resistance to all antimicrobial tested in this study was 100% in Klebsiella pneumonia. In Nepal, Klebsiella pneumonia was sensitive to imipenem, and 6.66% of Klebsiella altituga were imipenem resistant. In India study, Klebsiella species show resistance to imipenem, that is 3.3%, and meropenem 22.2% respectively. In Myanmar, the prevalence of carbapenem-resistant Klebsiella pneumonia from clinical sample in the hospital was 6% in the Jolinta study, 43% in Miet study, 38.7% in the Milwaukee study. In the present study, Enterobacter was resistant to both imipenem and meropenem. In Myanmar, carbapenem-resistant Enterobacter bacteria were observed in 9.2% in the hospital setting. Transmission via the food chain and fecal oral transmission has the potential to spread carbapenem-resistant Escherichia coli to a healthy and younger population. After ingestion of contaminated food with carbapenem-resistant Enterobacteriaceae could become the pet of the intestinal flora of the healthy individual who have not been exposed to healthcare or antibiotics. If carbapenem-resistant Enterobacteriaceae carrier need antimicrobial therapy or hospital care, there is a risk to failure of standard antimicrobial treatments, overgrowth or CRE, and onward transmission to other patients. Antimicrobial therapy of carbapenem-resistant Enterobacteriaceae is very limited, with polymyxin, phosphomycin, aminoglycoside is the mainstay of therapy. The treatment of carbapenem-resistant Enterobacteriaceae remain a problem, particularly developing countries where expensive second-line drugs are unavailable or not affordable by the patients. The main information gained by this study is that the carbapenem-resistant Enterobacteriaceae emerge in the healthy person in the community. Therefore, there is a need for effective infection prevention and control measures and proper antibiotic policy to control the spread of fecal carriage of carbapenem-resistant Enterobacteriaceae. Let's move on to conclusion. This study is a community-based study that clearly demonstrates that apparently healthy person could carry carbapenem-resistant Enterobacteriaceae in his or her intestinal tract and may act as a reservoir of carbapenem-resistant Enterobacteriaceae in a community he or she lives in. These results are the alert for hidden fecal carriage of carbapenem-resistant Enterobacteriaceae in healthy individuals in Yangon region. Therefore, this study is anticipated to be of help for clinicians as well as microbiologists in increasing the awareness of the prevalence of carbapenem-resistant Enterobacteriaceae in the intestinal tract or normal healthy person, which are the potential source of endogenous infection. These are my references. Thank you for your kind attention.
Thank you, Dr. Amy San, for your presentation. Although most of the research on carbapenem-resistant Enterobacteriaceae are on clinical setting, there are very rare studies from the environmental sample or community. You highlighted the presence of the fecal contamination and presence of the CRE in the community and made it as the reservoir of CRE in the community. So I would like to invite anybody who want to raise the question or give comments.
If there is no more questions now,
Maji is asking questions.
yeah. You can, Mama.
I want to ask you, Doimisan, carbapenem resistant CRE. အဲ့တော့ခုန study တစ်ခုဟိုပါပေါ့နော်ဟို reference တစ်ခုမှာ India မှာတော့သူ resistant rate ကရဲများတယ်ပေါ့ 10% ပေါ့ကျမတို့စီမှာတော့နည်းတယ်ပေါ့ဆိုတော့အဲ့တစ်ခုဆိုလို့ရှိရင်ဒါဘာဖြစ်လို့လဲပေါ့နော်ဘာလို့မျိုးထင်လဲနောက်တစ်ခုကတော့ဒီတကယ်တော့ကျမတို့တွေကတော့ဟို you choice of antibiotic မှာတော့ကျွန်တော် in vivoပြန်ကြည့်တာပေါ့နော်ဒါတို့ဒီမှာတွေ့တာနဲ့ပဲကျမတို့ဟိုဘက်မှာကြောက်လန့်တကြားပြောင်းရမလားဒါမှမဟုတ် we need there whether we need there ဘာလို့လဲတခါလေးမှမလိုပဲနဲ့သုံးလိုက်ပြီလို့ရှိရင်ပိုသုံးတာလည်းပို resistant ဖြစ်မယ်လို့ဒါကျမတို့အားလုံးသိထားရဲဆိုတော့လေဆိုတော့ we might need the clinical correlation ပေါ့နော်ဒါပေမဲ့အခုခေတ်တာတော့ဒါ very asymptomatic ဆိုတော့အဲ့တော့ဒါလေးကိုမြန်ကျွန်တော်တို့ reverse ဖြစ်အောင်ပေါ့နော်ဘယ်လို clinical application လေးနဲ့ပါစဉ်းစားထားလဲပေါ့အဲ့ဒါလေးခုနအိန္ဒိယမှာကလေးတွေမှာ 10% လို့ပြောတယ်ဒီဘက်မှာတော့မြန်မာနိုင်ငံမှာတော့ pandemic resistance မရှိဘူးပေါ့ကလေးမှာလို့ဘာကြောင့်အဲ့လို high ဖြစ်တာလဲ
အခုအမပြောသွားတာ 10% ပေါ့နော်အဲ့ 10% ဆိုတာကဒီ introduction မှာထည့်ထားတာပါအမအဲ့ထည့်ထားတဲ့ 10% ဆိုတာဒီကလေးတွေမှာတော့မဟုတ်ဘူးဒါကြီးတစ်ခုလုံးမှာဒီ area တစ်ခုလုံးမှာရှိတဲ့ clinical samples တွေမှာတွေ့တဲ့ percentage ကိုထည့်လိုက်တာပါအမ 10% ဆိုတာဒီနောက်က discussion မှာထည့်ထားတာကြတော့ကလေးတွေမှာတွေ့တယ်ကလေးတွေမှာဒီမှာတွေ့တွေ့ခဲ့တယ်ဆိုတာဒီနေရာမှာဆိုကလေးတွေကကြတော့သူကဘာပြော high risk group တွေထဲမှာလည်းပါတယ်ပေါ့သူကလေးတွေမှာတချို့လောက်တာတယ်ကလေးက high risk group ထဲမှာပါလို့တော့တစ်ချက်ယူစားတယ်ဘာဖြစ်လို့လဲလို့ပြောအိန္ဒိယတို့ဘာလို့မှာဆိုသူကဒီ carbapenem resistant enterobacterial disease က environment cells ကိုရောက်နေပြီလို့ယူဆပါတယ်ဘာဖြစ်လို့ရောက်သွားလဲလို့ပြောရင် hospital drainage တွေကတဆင် environment ကိုရောက်တယ် community ထဲမှာကူးနေတဲ့ main ကနံပါတ်1ကကြတော့ contaminated food and drinks တွေကနေကူးပါတယ်အဲ့လိုကူးတဲ့အတွက် environment မှာလည်းရောက်နေပြီလို့ယူဆတယ်ဒါမှမဟုတ်ကလေးတွေနောက်တစ်ချက်ကကြတော့ဒီ paper တွေရှိတယ် United States တို့ပြင်သစ်တို့ဘာလို့မှာ paper တွေမှာဆို dogs တွေ bugs တွေ cats တွေအိမ်မွေးတိရစ္ဆာန်တွေမှာ animals တွေမှာလည်း carbapenem resistant enterobacterial disease ကတွေ့နေပြီအဲ့တော့ swine တွေမှာလည်းတွေ့တယ်လို့ပြောတယ်အဲ့တော့ recreational waters တွေမှာလည်းတချို့ paper တွေမှာဆိုတွေ့ရဆိုကလေးတွေကတပိုပြီး acceptable ဖြစ်တယ်လို့ယူဆတယ်အိန္ဒိယမှာလောက်ထားတဲ့ paper မှာတော့ဒီကလေးတွေမှာတွေ့ရလို့ထည့်ထားလိုက်တာပါရှင်သူအဲ့လိုကလေးတွေမှာဆိုရင်community ထဲမှာရှိတဲ့ကလေးတွေမှာဆိုရင်ဒီ CRE carriage rate ရှိရဆိုဒါလေးထည့်ထားလိုက်ပါရှင်အမနောက်တစ်ချက်အမပြောတာကြတော့ဒီ step ကcolonization step လို့ခေါ်ပါတယ်သူ infection နဲ့ colonization နဲ့မတူပါဘူးရှင်အဲ့တော့ infection ဆိုတော့ကျမတို့ treatment ပေးရမယ် colonization မှာ treatment ပေးမလားဆိုတာရှိပါတယ် colonization ကို treatment ပေးတာ controversial ပါသူကဒီ colonization step မှာကျမတို့ကဒီ treatment မပေးပါဘူးရှင်ဒါမျိုးဆိုကျမတို့ wait and see ပဲဖြစ်မယ်ဒါနဲ့ဘယ်လိုလူမျိုးတော့ပေးလဲလို့ပြောရင် high risk group တွေပါပေးတယ်ဥပမာ immunocompromised ဖြစ်နေတဲ့ patient မျိုးဥပမာဒီ organ transplant လို့ patient မျိုးဒါမျိုးဆိုရင်တော့ဒီfecal carriage ဖြစ်နေတယ်ဆိုရင်တော့treatment ပေးပါမယ်ပုံမှန်အခုလိုမျိုး asymptomatic patient individuals လို့ခေါ်တာပေါ့ community ထဲမှာဆိုတော့ colonization မှာကျမတို့ treatment မပေးပါဘူးဘာဖြစ်လို့လဲဆို carbapenem resistant enterobacterial disease ကို treatment ပေးခဲ့မယ်ဆိုသူ့ထက်မြင့်တဲ့ဆေးတွေပေးရတော့မှာဘာပေးမလဲဆိုအများကြီးအခုက choice က polymyxin ပေးမှာအခုဆို polymyxin colistin ကလေ colistin resistant gene တွေပါတယ် mobile colistin resistant MCR1 gene တွေရတယ်အခုနိုင်ငံတော်တော်များများမှာတွေ့နေတယ်မြန်မာနိုင်ငံမှာဆိုလဲအမတယောက်စိတ်နှစ်ကလောက်သွားတယ်အမတယောက်မှာဆိုလဲ colistin resistant gene တွေမှာလည်းရှိတဲ့အတွက်တော့လိုမျိုးဒီ decolonization လုပ်ချင်တယ်ပေါ့CRE ကို decolonization လုပ်ချင်တဲ့အချိန်မှာတော့ကျမတို့ဒီစေးမပေးပါဘူးရှင်ဟုတ်ကဲ့
Thank you Dr. Imi-san
it is အဖြေလေးပေါ့အဖြေလေးထပ်ပြီးတော့စဉ်းစားကြည့်တာသမီးလည်းပြန်ရှာဖတ်လိုက်လေ
ဟုတ်ကဲ့ပါရှင်ပါ
သူကဘာလဲဆိုတော့drain hospital drain လို့ပြောတာပေါ့နော်ဒါဆိုတော့ normal asymptomatic တွေမှာသူကတွေ့နေတာဟုတ်
ကဲ့ရှင်ပါ
အဲ့ဒါဘာလဲဆိုတော့အမတို့ကဒီ antibiotics တွေ animal feeds တွေမှာသုံးတာရှိ
ဟုတ်ကဲ့ရှင်ပါ
သုံးတယ် eupolymycin ကိုလူမသုံးရသေးဘူး animal တွေရောက်တယ်လေ
ဟုတ်ကဲ့ရှင်ပါ
maybe အဲ့ဒါလည်း reason ဖြစ်ဖြစ်
ဟုတ်ကဲ့ပါရှင်
Thank you Mamaji and now it is a time to close this neuro micro paper presentation and first of all I would like to thank to all four speakers Dr. Oma, Dr. Momo, Dr. Mintei Nai and Dr. Imi-san for your excellent paper presentations and secondly to all the audience for attending this virtual session and for active participation. And last but not the least, to the organizing committee, Myanmar Medical Association. And thank you so very much.